examination of the hip, and then you all will present the hip case to him, and we'll take it from there. Right? So without much ado, let me hand over the mic to Manish to take it forward.
So how many are post-graduate students here? Okay, so fine. So there is some advantage of a smaller audience. It can be more interactive. So how many of you have seen tumors? Which tumor have you seen? Can we have a mic?
Giant cell tumor.
Okay. Anybody else? Has anybody seen a malignant tumor? Yeah.
Chondrosarcoma.
You don't put your hand, just get up and talk. Let it be fun.
Chondrosarcoma.
Okay.
Osteosarcoma.
Osteosarcomas. Then what about exostosis, enchondromas? Have you seen those? Because those are more common. Aneurysmal bone cysts, simple bone cysts. Okay. Now, how worried are you when you see a case? If you see a case and suppose you get a tumor case in the exam, are you worried about presenting the case? Why are you worried? Because of lack of knowledge. So, the purpose of this talk is that at the end of this, you will want a tumor case in the exam because that's a case you're going to score on. And why is that? Exactly the same reasons that there is a limited knowledge of tumors with most of the examiners. And secondly, you should, practically speaking, logistically, you will not get a malignant tumor in your exam, because you can't keep the patient that long. So invariably, what you will end up with is either a giant cell tumor or an exostosis. And these are both very easy cases, and will tell you how to answer the questions and how to present your findings, so that you don't have to worry about a tumor case in future. So any doubts that you have, ask at that time, and at the end of this, we should be able to present the tumor case confidently. So what is the most important thing or finding that you need to know in tumors? Age. Without seeing the patient, if you know the age, you already have a short list of differential diagnoses. Look at, if somebody is more than 60, you know you're going to look at myeloma, METs, lymphoma. These are the things which are far more common. And if you look at those who are less than 10, you know that malignant tumors are not that common. You have to think of ABCs, UBCs, NOS, fibrous dysplasias, those kind of things that you see, or exostosis. 10 to 20, just keep this in mind. Any bone swelling or region has to be assumed to be malignant unless proven otherwise, because that's the age at which you get osteosarcomas and healing sarcomas. And they can look anything on the X-ray, they can look like infection, they can look like benign tumors, but unless you biopsy them and prove what it is, you should not be operating on them. And that's one rule you should follow, not just for exams, but for life. I think Dr. Kalkanis will tell you, recently there was a boy who looked like he had an infection in the distal femur. And we biopsied him. We all thought it was infection, and it came out to be an osteosarcoma on the biopsy. So this is something which you must keep in mind. 20 to 40 is the age at which you get giant cell tumors. And giant cell tumor is very common in India. For some reason, Indians and the Chinese have 20 times higher incidence of getting giant cell tumors compared to the Western population or the Caucasian population. We don't know why. One of the theories is an endemic deficiency of vitamin D, has probably some etiological factor. We don't know the reasons, but this age, young adults, think of giant cell tumors, but don't assume giant cell tumor as a diagnosis till you have proven. Now, why is age important? You can see these are 3 scapular tumors that you can see. At 14, what would you think of? What comes in a flat bone? Ewing sarcoma. Okay, pelvis, scapula, axial skeleton. Think of Ewing's. You look at 67-year-old man, that was a metastatic tumor. And if you look at that 45-year-old patient, that was a giant cell tumor. Now, age itself can give you a differential diagnosis once you know the site. Site is also important. We'll talk about some tumors having a predilection for specific sites. Now look at this. The one on the left is a child. You can make out from the open growth plates. What do you think it is? Just a spot diagnosis. Very well defined lesion, sclerotic border, child. What is it likely to be? It's a UBC. The same kind of lesion you see in a 60-year-old on the right hand side. What is this likely to be? It's a metastasis. So, age is extremely important before you put your differential diagnosis. Now, when you see a swelling, suppose you get a case of a swelling in the exam like this, what do you need to know? The first thing you need to know is this a bone swelling or is it a soft tissue swelling? And if you think it's a bone swelling, then you want to know it's coming from the bone or is it a joint swelling? So, joint swellings are different, as you will see here. So, joint effusion, how do you make out? How do you make out whether it's a swelling? Suppose you get an osteosarcoma coming from distal femur or a giant cell tumor from the proximal tibia. How do you know that this is not a synovial effusion or joint swelling or PVNS? Just feel the joint line. So if you can feel the joint line, you are not seeing the joint swelling. Okay, then the swelling is below the joint line or above the joint line, and that's one easy way of finding out the difference. A big clue is the swelling solitary or multiple. Like I told you, most common case that you may get is an exhaustosis. And if it is a hereditary multiple exhaustosis, if you ask the patient, do you have any other swellings, they will tell you, I have one there, but they are not bothering me. Then you know that this could be an exhaustosis. So, which are all the swellings that you know which can be multiple? Tell me anybody. Osteosarcomas are not multiple, Ewing's are not multiple. It's generally benign, so it could be Olier's disease, where you can have multiple enchondromas or cartilage dysplasias. Fibrous dysplasias can be multiple. Okay. Brown tumors can be multiple. Myeloma can be multiple. Metastasis can be multiple. So depending on the age, you are going to put your differential diagnosis. But if you look at a list of swellings which can be multiple, that list is small. So if you get multiple swellings, you already have a differential diagnosis which is small, without even seeing the X-ray or touching the patient. Look for these characteristic things. Anybody wants to take a guess? What are you seeing? What is on the left?
Neurofibromatosis.
What has happened? Spot diagnosis, if I put up this picture. So it's a neurofibrosarcoma happening in a patient with multiple neurofibromatosis. One of them has converted into a sarcoma, which is a known thing or a known fear with patients of multiple neurofibromatosis. What's on the right? If you see something like this in the exam, what are you going to think of? There is an obvious length discrepancy, there is deformity, and there are swellings. What would cause that? So it could be exhaustosis, it could be Olier's disease. So this one, if you look at the swellings on the toe, the foot, And the way the deformities are, this actually was an Ollius disease. Most tumors are metaphyseal. That's why, like we said, if you want to narrow down your differential diagnosis, if you had a diphyseal tumor or an epiphyseal tumor, your differential diagnosis becomes narrow. So which are the conditions that you see are diphyseal? I've listed them. You can just read them. So these are all, that's all. These are the only things which are in the diaphysis. Now the moment you see a swelling in the diaphysis, don't go and say GCT in the exam. GCTs are never diphyseal. Okay? So that's a big clue to you that diaphysis means it's more likely to be an ABC than it's going to be a GCT for the patient, if you're thinking it's big. Now we talked about characteristic sites. So when you look at tibia, what are the swellings that you see in the tibia? Which come, say 80-90% of the time these tumors will come only in the tibia. Adamantinomas, osteofibrous dysplasias. Okay, these are two things which you will always see in the tibia, and that in the anterior cortex of the tibia you get a mild bowing. So if you see that, the differential diagnosis becomes really narrow. What are the swellings that you get in the finger? Most commonly you get enchondromas on that. Malignant tumors in the hand and in the foot are very rare. So think of benign when you see these swellings. What is the soft tissue swelling which comes in the finger that you see here? Commonest. GCT bone, I've said soft tissue swelling. Giant cell tumor tendon sheath. Okay, or what is called as also nodular PVNS. So these are benign tumors which you'll often see in the finger. So if it is a soft tissue swelling mobile over the bone, think of giant cell tumor tendon sheath. If it's a bony swelling, think of enchondroma in the fingers. Distal radius. So 9 out of 10 times, without seeing the X-ray, if you say GCT, you will be correct. But you will not operate this patient without a biopsy. Okay, that is one message very strongly put in, because in that 1 out of 10 cases, you will make a big mistake if you operate without a biopsy. And we'll show you some examples of that. It's very important to know how fast the swelling has grown. It can give you a clue. Now this picture on the left that you see with the big calf swelling, the patient says that I had a small swelling for 15 years and then suddenly it has grown in size over the last 3 months. So what does that tell you?
It has gone malignant.
So it's a secondary chondrosarcoma. So this is an exostosis which was there, and then there has been a malignant transformation, and now it has become malignant. So when something has grown rapidly over the last maybe months, you're thinking of something aggressive, something malignant. The patient on the right said, I have had this swelling for 7 years. It's been growing slowly. And actually he came for treatment only because he started ulcerating and he became foul swelling, so his neighbors forced him to come to the hospital. He would have otherwise not come, it was not bothering him. What is this likely to do? So this was a flat bone. What swellings do you get in flat bones? In adults. Chondrosarcoma. So this was a low-grade chondrosarcoma. Okay, so it is important to know how the swelling has grown. Now if you see a child with a swelling like this, I think there is no differential diagnosis. We all know this is going to be a malignant tumor on that. So aggressive, sometimes GCTs can look very aggressive and they can look like malignancies, and sometimes malignant tumors can look benign. But don't get confused if you find that the history is short. So all these swellings have grown rapidly, so we are first thinking of a malignant tumor. So when you examine the swelling, what are you going to do? The standard rules of examining any swelling. So what are you going to do? Size. Where is it arising from? What is its relationship to the surrounding structures? Okay, so dilated veins, scars, sinuses. The standard thing that you would do in any swelling is what you would do for any swelling that you get in the limbs. All that. Okay. Now, you must check for abnormal mobility, because if there is a pathological fracture, you are not going to make the patient walk to examine the gait. All that. Look for clues. What is this? Yeah. Capillary spots. If you see on the body, then patient has come to you with a swelling. It could be related to neurofibromatosis. You don't know whether it is benign or malignant till you examine further and you have more information. But this is a big clue to you of what it could be. Now, don't forget to examine the lymph nodes. Now, why are lymph nodes important? Now, you probably have already know or have read that sarcomas generally do not metastasize to the lymph nodes. They generally undergo hematogenous spread to the lungs. So 95% of the time, if the metastasis has happened in a sarcoma, it will be to the lungs. But I am telling you to examine the lymph nodes. Why? You see that list? Many examiners know this list. They are going to ask you, which are the 5 tumors that can go to the lymph nodes? Okay. If you ask me, I don't expect a postgraduate to know. But synovial sarcomas, rhabdomyosarcomas, you see here clear cell sarcomas, epithelioid sarcomas, and lymphomas will have lymph node enlargements. Now you can get lymph node enlargement even in infections. Remember that. So when you see something which is a swelling on the limb and you see lymph nodes, you have to keep a differential diagnosis in mind. More importantly, if you had a metastatic disease, suppose you are seeing a metastatic bony tumor, presence of lymph nodes, it may actually guide you towards what is a possible primary form. So you must examine the lymph nodes, don't forget about that. Also, you saw that scapular swelling which I showed you before in a 60-year-old, and I told you it's the Mets. Don't forget to examine the genitals. It was actually a testicular swelling which had gone to the scapula. And I am not ashamed of telling you that I had not examined the patient. I had not examined the genitals. So the pathologist asked me, has it come from the testis? And I said, no, wait, I'll have to check and tell you. So in the exam, if you make that mistake, you're going to fail. If the patient has a scrotal swelling and you've not seen it, and there was a scapular swelling and you're not correlated, you could fail that exam. And if you looked at both of them, you're not going to be asked too many questions. You're going to crack that case. So that's the difference that you should know. So don't forget the lymph nodes. Don't forget to examine the testes. And don't forget to look for additional signs like capillary spots or neurofibromas that may be hidden and the patient may not tell you about it. Look at other subtle signs. If patient has no hair, could be bald, but ask whether he's got any chemotherapy in the past. There are times when patient will take 1 or 2 doses of chemotherapy and then come to you, to the hospital for treatment, because somebody has already tried their hand. You will find a scar. Somebody may have done an open biopsy. You may find that somebody has given radiation, so you will see that pigmentation or hyperpigmentation of radiation. These are all clues that you can get to as to what could have happened in the past. We all talk of neurovascular involvement. We all write NIL, NVD. I, in 25 years, have seen only 2 or 3 patients who have come with a neurological involvement or vascular involvement with a tumor. It's very rare. It is more common if the patient has been operated in the past and then there is a recurrence, then the neurovascular involvement is more common. And the first sign that you see of, say, vascular involvement is going to be swelling, because it's the vein which gets obstructed first, not the artery. Most of the time, even if the tumor is engulfing the artery flow continues to be good and you don't find an arterial compromise in the patient. But you'll see venous compromise, you'll find swelling on the limb, all that. As far as nerves are concerned, most of the times the tumors will push the nerve away. So you don't get neural involvement unless it's a bad disease, sometimes metastatic disease, and we've seen one recently where it was a lung cancer net coming in the humerus, coming as a soft tissue mass and invading into the radial nerve, presenting with a wrist drop. So those are rare situations. Remember, so nerve involvement is rare, but if you see nerve involved, think of a tumor arising from the nerve. Again, those are rare, but then you will see signs, suppose it's a schwannoma or a neurofibroma, you see tinel sign, which becomes positive. So if you find a tinel sign, then you know that this could be a nerve sheath tumor, and your differential diagnosis becomes narrow. Vascular involvement, I told you that veins will be the first thing involved. You can see from that MRI, the artery running in the middle, but you don't get arterial compromise. So what are the things that you will do if you are suspecting a tumor? What is the workup? Even if it is a soft tissue tumor, you will get X-rays done. Why? Give me answers. Suppose you know that the tumor is mobile over the bone. Bone is not involved. I will still get an X-ray done. Some tumors show ectotopic ossification. Okay, and that can give you a clue. Synovial sarcoma show calcification in the tumor. Hemangiomas, AV malformations will show you phlegboliths. So don't miss those clues. So X-ray has to be done, not because you are an orthopedic surgeon, but because it can give you clues as to what is happening. Tumors which are not mobile, definitely you will do an X-ray, because suppose you had a tumor which is stuck to the periosteum or very close to the periosteum. You can't tell it's a bone tumor or it's a soft tissue tumor till you've got more imaging done. Now, would you do a biopsy before doing the imaging? Okay, let me first know what the tumor is and then I do the imaging, I'll save money. Never. First imaging and then biopsy. Why? Imaging will tell you which is the best site to biopsy, and deciding where to biopsy from is probably going to be the most important thing you're going to do for that patient. Okay. Now, I don't know what the tumor is. I send the patient for an MRI. Do you expect the radiologist to tell you what the tumor is? Most of the times, this is what is happening. You ask the radiologist, tell me it is osteosarcoma or Ewing's. They cannot tell you. They can only tell you it's aggressive, the signs that they are seeing, there is edema in the marrow. MRI cannot tell you whether it is benign or malignant. Don't do an MRI to find out it is benign or malignant. Okay, the reason, why would you do an MRI? To see the extent of the tumor. So you want to know how far it is going in the bone. So you want to, what kind of an MRI will you do? If you saw a distal femur tumor, let's say you are suspecting a giant cell tumor, what MRI will you do? What will be your instructions? Will you ask for an MRI of the knee? Commonly this is done. MRI of the knee will not give you sequences like T2 which are required to make a diagnosis. How do you diagnose a GCP? How do you get a clue of GCP on MRI? It's dark on T2 because of the hemosiderin. You know GCPs, if you look at their surface, they are tan brown in color. And that's because of the hemosiderin in the tumor. And that looks as a dark signal on T2 sequences, pure T2 sequences. So If you ask for a knee MRI, one thing is they will not image the entire bone. Only that small segment of the distal femur will be imaged and you may not get the full extent of the tumor. So you have to specifically say, I want tumor sequences. I want the entire distal femur and a screening sequence to go right up to the joint. When you get X-rays done for trauma, don't you do hip to knee? Full bone is imaged. The same way, if you are looking at any tumor, you don't want to miss skips. So even in an osteosarcoma, you must have a screening sequence which will screen the entire bone from one joint to the other joint. So ask specifically that they are suspecting a tumor, don't say MRI in knee. Okay. In the exam, that is a trick question. Often they will ask you this and trap you on that. But you say, no, I don't want a knee MRI. I want a tumor sequence. Okay. What blood investigations will you do? What are the blood investigations that are important to us? If I see a lytic lesion in the bone, what should we do? CBC, ESR, because infection is always a differential diagnosis. Metabolic profile, serum calcium, phosphorus, alkaline phosphatase, because hyperparathyroidism, brown tumors, all those can be picked up. What are the signs? What would you see on the reports? Either an elevated calcium or an elevated alkaline phosphatase. These are the two screening tools. Uric acid you will ask for, especially if there are joint swellings or if there are soft tissue swellings, which could be the gouty profile, which you can see. So these are the blood. You must, when you ask for an investigation, your examiner is going to ask you, why are you asking for this investigation, and you should have an answer. Why are you asking for an investigation? Now, one by one, I want all of you to tell me what are these? What do you suspect? And what are the findings that you have from the X-rays? We'll start. Yeah. Like, I'll give you an example. The first one, let's say, if I have to say, it's a very well-defined lytic lesion in the distal femur. Okay. There is a little bit of periosteal reaction, which you can see. There's a bump on that bone, so there is a distortion of the cortex. But it is very well defined, you can see. What do you think it could be? If I tell you this patient is 30 years old, your first diagnosis, differential diagnosis, is going to be a giant cell tumor. So you are getting there now. Now you know the rules and you apply that to this. Now same way, I want somebody to tell me what are you seeing on the second X-ray. Come on, one of you, just get up and... If you don't recognize this, you will fail in the exam. So, it's a possibility, but what are you seeing here? It can't be the first possibility. This is a bone-forming tumor. Aren't you seeing sclerosis? Are you seeing a periosteal reaction? You're seeing a Codman's triangle? Okay? So, this is a malignant tumor, most likely an osteosarcoma. But you are very correct when you say Ewing's also, because they can look identical on X-rays and you will have to do a biopsy to find out. And to confuse things further, there is an entity called as a round cell osteosarcoma, where it looks like Ewing's, but it also has osteoid. Okay, and they are treated as osteosarcomas, they are not round cell tumors. You already saw the X-ray on the left, very well defined, you can see. What about the X-ray on the right? Eccentric, well-defined, sclerotic border, benign or malignant? Looks benign. Okay. How will you confirm? You don't want an MRI? Before doing a biopsy, do the MR. If you're going to do an MR, do it before the biopsy. Show you why. You have all heard of onion peeling. Is it a sign of any particular thing? Look here. First one is infection. Second one that you are seeing is osteosarcoma. Third one you are seeing is EVs. I don't think from the onion peeling you can tell what it is. It just means it's an aggressive tumor growing in fits and bursts. When you see some periosteal reaction, then again it grows. Again you see a layering happening. It is also seen in histiocytosis. So when you see a laminated periosteal reaction, your differential diagnosis includes infection, tumor, and histiocytosis. Remember that, give all the differentials at that time. What happens if you don't biopsy? You may assume the diagnosis of infection. You end up doing a debridement, and this turns out to be EVs. And now what happens? What happens if you debrided an EVs? One is the patient lymph salvage is doomed. And the other is, yes, you're opening up all the vascular channels and allowing the tumor to spread. It's not something you want to do. You will not, as a rule, I think the only message that I would have today for all of you, forget the exams, is do not assume infection in this age group. 10 to 20 is an age group at which osteo and bleedings are common. Even if it is you are looking like infection, patient has fever, all the signs, ESR is high, CRP is high, even then you will do a biopsy before you debride the patient. Okay. It's very, very important not to burn the bridges for the patient. Like I told you, if you see any bone lesion which is even slightly aggressive in this age group of 10 to 20 years of age, it's an osteosarcoma. Okay. Unless proven, it may turn out to be infection, TB, histiocytosis, anything afterwards. GCTs are not metaphyseal generally, but if they happen, if they come before the growth plate closes, you will find them metaphyseal, particularly in the distal radius you will find that they could be metaphyseal at that time. So don't get confused on that. So if the patient is elderly, which we say today more than 60, think of metastasis. And if you are thinking of metastasis, always get a chest X-ray done because you may pick up a primary. A lung is a, which are the common primaries which go to bone? Get up, just name them. There are five primaries which go to bone. Small cell?
He's asking for the primaries.
Which are the primaries? Lung cancer, he said. What else? Prostate, thyroid, breast, and kidney. Just remember these five. These are the commonest which go, but every tumor can go to the bone. Okay, there is no the rule that a head and neck cancer can't go or some other rare cancers can't go. We've seen meds from most unusual cancers. So again, a biopsy is often necessary if you don't know what the primary is. But if you are suspecting a med, it is worthwhile trying to identify the primary before. And how would you identify the primary? Like I told you, you could get a chest X-ray done. You could get a sonography done to look at the kidneys. A breast examination could tell you whether there is a hidden breast lump. And you'll be surprised how many times we have found a lump which the lady is not aware of. And it's come with a med at that time. So remember, clinical examination, thyroid may be a visibly obvious swelling. So you have to look for these things when you are suspecting a med, particularly on a patient if you have it in the exam. Multiple lesions again mean meds, myeloma, lymphoma on that. So the one on the left was a meds from a breast cancer, the one which it's already spine has been operated and still there are lesions in the femur and there is a fracture femur which you can see. The one on the right was a myeloma with multiple lesions which you can see on that. And again, you must image the entire bone because when you are planning surgery for a meds, you have to make sure that you don't leave something behind which can create another problem for the patient. This is another example of multiple lesions in the same bone, the skips, which again you can get in meds. This was a renal cell cancer with meds. So when I say chest X-ray, look at this. There's an obvious lung primary sitting there. Now if the chest X-ray doesn't show you, we get a PET CT scan done. So if you're suspecting metastasis, get a PET CT scan done, because if you find a primary, for example the lung, the biopsy should be done from the lung rather than from the metastatic disease, because today there are targeted therapies which have improved the survivals of these patients. And you don't think of being in a hurry to operate the secondary. I think you'll have to convene a tumor board and get everybody involved in it and then decide the treatment for that particular patient. So we've already spoken. Multiple sclerotic lesions again narrows down your differential diagnosis. So you have to get a PSA done. Now, how do you identify Paget's? How do you differentiate it from sclerotic mets from prostate cancer? Well, the whole bone is involved. It's not isolated spots. Plus, you have classical signs of Paget's. You'll find thickening of the cortex. You'll find remodeling changes on the X-rays that you see. And then when you do a skeletal survey, you may find multiple bones involved instead of just one bone being involved. But unlike in the West, we don't wear hats, so you don't get these symptoms of the hat size changing. Skull is not very often involved in the Paget's that we have seen, but alkaline phosphatase can be high. So that is one marker which you can use to diagnose if there is a rapid turnover or remodeling happening in the skull. What is this lesion? Anybody? The fibular lesion is obvious, but can you see another lesion in the distal femur? So when you see an X-ray, don't jump to a conclusion. See that X-ray carefully, otherwise you've got only half the findings. Okay, this X-ray, at least 6 examiners in the past have taken from me to put it in the exams. Okay, so these kind of X-rays will come to test whether you are really observing everything carefully or not. What was this? When you see multiple lytic lesions in different bones, what are you going to do? This is a 35-year-old. So what are you going to do? Even before a biopsy, you are going to get the metabolic profile done, like I told you. Because a biopsy is only going to show you cystic changes. It may not reveal the diagnosis to you. It may be a giant cell containing lesion and you may get confused. Now this patient was actually a multicentric giant cell tumor. It was not a brown tumor because alkaline phosphatase was normal, PTH was normal, calcium was normal in this patient. And we had to operate both the sites. This is another patient. Can you see that lesion in the proximal humerus? So you see the parameters down, which we've written. You see the PTH level, see the alphos high. This was primary hyperparathyroidism. You can see the system EB scan. Look at that adenoma in the parathyroid. So this is the commonest reason why you get primary hyperparathyroidism. So if you find PTH high or if you have signs of hyperparathyroidism, don't forget to do either a high resolution ultrasound of the neck or a system EB scan. Multiple lesions. This patient was 64, was told you've got meds and there is no cure for you, your lifespan is limited. They came running to us. And we biopsied this and this was tuberculosis. Remember, multiple lesions, tuberculosis is a confounding factor. Again, Gautam will tell you how many times he's seen in the spine. It comes as meds, but it turns out to be TB. I remember when I joined Tata Memorial Hospital, we had a lady who came with paraplegia, obvious lesion in the spine, also a breast mass. We biopsied both and it was tuberculosis. It wasn't a tumor. And Tuberculosis in that setting is a very happy diagnosis. On that. So do not tell the patient anything till the time you have evidence that this is mixed. Don't reveal the diagnosis of cancer unless you have evidence that this is cancer. You can discuss it with them, tell them there is a possibility, but there is a chance that this could be benign. Now we've had patient who's come with multiple lung lesions. One of them was TB, the other one was mixed. You can have both of them together also. And the same thing in the spine we've had. At different levels you have involvement. One of them was TB and one of them is a mix. And you have to be careful about this. If you treat one and the other grows, then you know that you have not treated the other one on that. So TB is a confounding factor for malignancies. Spot diagnosis. Chondroblastoma. You see an epiphyseal lesion in a child. There are only two differentials. Either it's infection or it's a chondroblastoma. Chondroblastoma more likely. Characteristic patterns. No differential diagnosis. The first one, anybody? What is this? You will see these on spots on your X-rays. Eccentric lesion, well defined, likely with a sclerotic border. What is it? Non-ossifying fibroma, fibrous cortical defects, these are common and these are picked up incidentally when the imaging has been done for something else. The child may have fallen, you got an X-ray done and incidentally you picked up these findings. What is this? All these. There is no differential diagnosis here. Okay, at the most it can be a chondrosarcoma, but it's rare. 99 of the 100 times it is an enchondroma. So these are some of the lesions which you can treat without a biopsy. You don't require a biopsy in this characteristic setting. These should not be biopsy at all. Okay. And definitely not operated. We've seen patients who have come with surgery done for this on that and then getting infected. Now, we saw enchondromas in the fingers. What about this? Is this enchondroma or chondrosarcoma? Anyone? The rules in the long bone are different. Any chondroid lesion in the long bones which has caused either a cortical expansion, periosteal reaction, scalloping, cortical break, it's a chondrosarcoma. Okay, you can assume it is a chondrosarcoma. Okay, any lesion which is growing, any chondroid lesion which is growing in the long bones is a chondrosarcoma. That rule does not apply in the fingers or in the toes. Okay, where the lesion can grow and cause a fracture. If you see a pathological fracture from a chondroid lesion, as you can see in this case, now here it was important to guess this because this baby was actually being treated for breast cancer and then she developed a pathological fracture and it was assumed to be a med till the time we saw the X-rays. Now this is actually a second primary. This is a chondrosarcoma with a fracture and this is not a breast cancer med. So it changes the prognosis completely for the patient and the treatment that you would do will change. So recognize the calcification, recognize the expansion of the bone. What is the first case? Anybody wants to take a guess? What is this? 40-year-old. Looks very bad, whatever it is. So, I think our first diagnosis for all of us is a malignancy. What about this? This is a 22-year-old. Nice lytic lesion, very well defined, eccentric. So remember, X-rays are not reliable. These are both. This is a cancer tumor, and this was a telangiectatic osteosarcoma. Osteosarcoma to tumors is what TB is to orthopedics. It can look like anything on that. So we spoke about getting MR done. I'll show you some examples. Can you see this lesion? If you don't image the whole thing, you can miss the skip. So you can see there. You'll sometimes see this. And an MRI will actually tell you what is the relationship of the tumor to the neurovascular bundle, which is going to help you plan the limb-saving surgery for a particular patient. So we always get MRIs done. Do you need contrast? A common question asked. Last time I told you that you will ask for MRI with tumor sequence. But do you need contrast? If you don't know, say yes. Why? We look at this situation. Now, do you see this huge lesion in the pelvis in a child? So get an MR done. This is what you are seeing, multiple fluid levels. But in this 12-year-old girl, I don't know whether this is a telangiectatic osteosarcoma or an ABC. So, how do I know? Even if I want to biopsy, this lesion is very big. Where do I biopsy it from? If I don't biopsy it from an obviously malignant area, I can miss the diagnosis. So we get a contrast sequence done and we can see that there are no solid enhancing areas, which means it is likely to be a primary ABC on that. So if you have a primary ABC, how do you biopsy? Where do you biopsy it from? You have to scrape the wall because the diagnosis is going to be from the lining or from the septate that you see. Otherwise you get only blood. If you just put in a needle and aspirate, you will get only blood. And it will be a negative biopsy. We'll show you how to do that. Now look at this lesion. If you do a contrast, you realize these black areas are all necrotic. If you biopsy this from the necrotic area, you don't see any cells and you will not get a diagnosis. And your needle biopsy is going to fail. So you have to target where the uptake is. You see the uptake here? Or you see the uptake here, this is very close to the neurovascular bundle. So you will biopsy from here and get your diagnosis. So you must use contrast. Primarily, if you don't know the diagnosis, use the contrast, particularly cystic lesions. What do you think is this? Is it? Can it be an ABC? Now, why am I asking you? Is the treatment going to change between a UBC and an ABC? Yes, very much so. UBCs don't have much danger. They will often heal after a fracture. They don't require a biopsy. ABCs with a fracture are dangerous conditions. They can be very aggressive. They are still benign, but they can become very aggressive. They may look like a malignant tumor, and they are difficult to treat at times. And the treatment is not just injection of steroid, it is going to require sclerotherapy. So we'll talk about ABCs. It's not all simple. Single cavity also can be ABC. And sometimes even the pathologist may find it difficult to give you the diagnosis, but anything which has expanded the bone this much requires more investigation. So we've done a contrast MR. Can you see the uptake here? So if you biopsy, you target this area, not the rest of the area. And this was an aneurysmal bone cyst structure. Though it has a single fluid level, you can see these areas have uptake. This is a 18-year-old. He's come with a lesion in the distal femur. Very nice fluid level, you can see. Multiple fluid levels you can see. What is it? ABC or telangiectatic osteosarcoma? So I'm not going to bet on anything till I have a biopsy, and I've been wrong so many times that we'll get a contrast MR done, biopsy the area which shows the uptake, and then take a call. So this was not picking up any, there was no nodular enhancing area. We did a biopsy of the wall, and this was an ABC because you can see these septate with giant cells, some giant cells in it. This is a classical appearance. You don't see much cells here. You see there are no nuclei, proteinaceous material, only cell lining. So this is an ABC.
What are the chances that you scrape the wall during your biopsy and then this will stimulate a healing process?
Very likely. So that is what is called as a curopsy. So when you, with a needle, you curate the wall, take your diagnosis, and we let the patient go for 6 weeks, come back after 6 weeks. If they start to heal, about 30% of them will go on to complete healing. So we will give them a chance. The problem is if they have a fracture. ABCs with a fracture are dangerous, as I told you. They are more aggressive and you can end up with problems. So we use, otherwise most of the times ABCs will get sclerotherapy and they have more than an 80% chance of healing. Like you can see in this young patient, it's healed completely and you don't require surgery most of the time. Now if you see an ABC, don't leave it at that. 50% of ABCs are secondary. That means there is another primary tumor. It could be a giant cell tumor, or in this case, which you see in the epiphysis, this was a chondroblastoma with a secondary ABC. So you still need to do a biopsy, and that is why I told you all ABCs require a diagnosis. So they require a biopsy before you operate on them. What is this? 11-year-old boy, lytic lesion, metaphysis, distal femur, multiple fluid levels. Radiologist reported this is likely to be an ABC. We biopsied this. I told you, all ABCs are biopsied. What do you see? See this? This is osteosarcoma. This is a telangiectatic osteosarcoma. And if you don't biopsy this, you would have missed it. And remember this patient because the radiologist reported ABC, pathologist reported osteosarcoma. Patient believed that it is an ABC, didn't believe the pathology, went away, did not take treatment. Came back with a bigger than football sized tumor and lung metastasis. So, do not assume ABC, prove it is ABC, make sure you biopsy from the wall and get the diagnosis. These are lesions commonly seen in any orthopedic surgeon's practice. Don't get fooled. I showed you this patient before, very well defined. Look at the MR, multiple fluid levels. 3 different MSK radiologists, means musculoskeletal radiologists who are specialized in musculoskeletal radiology, all reported ABC. We thought it is ABC. We biopsied. This was a telangiectatic osteosarcoma. Don't believe the X-rays or radiology. You need to have a diagnosis. What can you diagnose on MR? A lipoma. You are 100% correct in picking up fat on MRI. You will find a lesion which gets completely suppressed on stir sequences. That's a fat containing tumor. So this is a lipoma. So you don't need to biopsy these tumors. 23-year-old boy who had a fracture while playing football. He just said he tripped over the ball and ended up with a fracture. What is this? Anyone? Is it a pathological fracture? Very obviously this is a pathological fracture. History also suggests it, but radiology is very clear. It looks like a very well-defined lytic lesion in the diaphysis of the femur. In a 23-year-old, what can it be? It can be anything, including a UBC. So it was assumed to be a UBC, and a femur nail was put. This was done in a big corporate hospital in Bombay. So I'm telling you, these are not things which happen in villages. They did send the reamings from the canal for biopsy, assuming that will give them the diagnosis, which didn't show anything much. So the patient started to heal and everybody was happy. You can see that the fracture is healing. But if you look at that X-ray on the right, it is something odd is happening. It's not really healing. It's actually growing in size. And he's come back with a big mass in the thigh. And this is not callus. So this was then biopsied, and this was a high-grade pleomorphic sarcoma. Now these are unusual tumors to happen in the bone, but I'm just telling you, pathological fractures in the young, don't be in a hurry to nail them. Now we have a problem. There is a nail contaminating the whole canal. How do you get margins here? There is no other disease and no metastasis. So we have to remove the entire femur here, which otherwise would have been just a simple resection. And can you see that nail inside, and can you see that tumor? So the commonest indication today for doing a total femur replacement is a nailed pathological fracture. What is the other workup that you do in any case suspected to be malignant? So we spoke about X-rays, we spoke about MRI. What else would you do? So we do PET scans today, but that's not the standard of care. The standard of care is a CT scan of the chest. You first do an X-ray of the chest, because like I told you, 95% of the metastasis will happen to the lung if METS has happened. What is the drawback of an X-ray versus a CT scan of the chest? X-ray can pick up lesions which are generally bigger than a centimeter size, whereas CT scan can pick up millimeter size lesions. Now that is important when you are looking at a patient, say with an osteosarcoma or an Ewing sarcoma, because the prognosis changes. So patients who are presented with metastatic disease have a different survival. Anybody knows what is the chance that a non-metastatic osteosarcoma is going to be cured today in India? 60 to 70%. Very good chance of being cured with chemotherapy and surgery. What is the chance if it is metastatic? Suppose you have lung mets. So if you had multiple lung mets which cannot be resected, your survival is nearly zero. If you have mets which can be resected, your survival is close to 30 to 40%. Which means it is important for you to know how many mets are there. So CT scan is a standard of care today. So you, in any patient suspected with a malignant bone tumor, you will do a CT scan of the chest. And it is not just any CT scan, it has to be 2 millimeter slice thickness so that you don't miss lesions which are bigger than or smaller than 2 millimeters on that. So you will do a spiral CT chest, so it has to be contiguous slices. Remember, there are times in protocols where they will skip interbetween areas. So they will do slices which are thin, but they will miss segments. So we say 2 mm contiguous slices like you do for a 3D CT. And you do a bone scan. Bone scan because 5% mets can happen in the bones for an osteosarcoma or for an illness. So today the standard of care is this, but if you do a PET CT scan, you do a PET CT scan with a breath hold CT thorax. PET CT with the standard CT will not pick up the lung nodules. You have to do a separate breath hold CT thorax. 2 mm contiguous slices to pick up the CT, the lung nodules. What else does the PET CT do? In rare cases, it will pick up unusual sites. It will pick up lymph node mets. There are times when we have picked up adrenal tumors in patients with soft tissue sarcoma, and they've got fortunately treated. But there are times when it's not still the standard of care, so in the exam, you don't say PET CT is the standard of care. If you have it, you can do it. And today the cost of PET CT has come down, and the advantage is that it can be a single investigation instead of doing two separate bone scan and CT chest. Another advantage of PET CT is that if you do a PET CT before chemo, and if you do a PET CT after induction chemo before surgery, you can actually tell what has been the response to chemotherapy. And that's a clue to the prognosis of the patient, and it may help you decide whether you want to do a limb salvage in a borderline case or you want to go ahead and do an amputation. So look at this example. See the uptake here, and see after chemotherapy there is no uptake. Look at the uptake here. There is very little uptake. So even if the size of the tumor has not changed, if the metabolic activity has reduced to less than 50%, it's a good response to chemotherapy. Now conversely, look what has happened here. This is previous to chemotherapy, and this is after chemotherapy. What has happened? It has actually increased. It means this tumor is resistant to chemotherapy. What happens to this patient? This is a death sentence. There is no cure for this patient. So there is no point in making this patient go through expensive limb salvage surgery. It's not going to be cured. So if they are financially constrained, don't make them spend money on limb salvage surgery. You can pick on, you can see the lung nodules, you can see that lymph node mets which are there. So you've heard about biopsy. When do you biopsy? What lesions do you biopsy? I showed you some fibrous cortical defects. We saw some enchondromas. Do you biopsy them? So which are the lesions you biopsy? As a rule, how do you remember which are the lesions you biopsy? Every patient you are going to operate ideally should be biopsy. Fibrous cortical defect is not something you are going to operate, so that doesn't need a biopsy. Osteoid osteomas have a characteristic appearance, you don't need to biopsy. Enchondromas in the fingers or in the toes, you don't need to biopsy. Lipomas are very characteristic on MRI, you don't require to biopsy. But everything else, you are going to biopsy. So osteochondromas, you don't need to biopsy if it is a characteristic appearance, but you must make sure that you are not dealing with a secondary malignant change. I will show you examples. So you can see that exostosis there where biopsy is not required. All that. Okay. Fibrous cortical defects, like this was a boy who fell down when he was playing football, and this was an incidental finding, so you don't do anything for that. So this is an enchondroma. Unlike the previous case which I showed you, there is no expansion of the bone, no scalloping. In short, no signs that there is any damage to the bone. So this is something for observation. You don't need to biopsy this. How do you do a biopsy? Probably the second most important thing that you're going to learn in this. Anybody who do open biopsies? Have you seen open biopsies? Okay. No open biopsies at all. Open biopsies, if required, should be done in a tumor center by the surgeon who is going to be doing the final surgery, because a badly placed incision or a badly done open biopsy is going to negate any chance of a limb salvage procedure for that particular patient. Our commonest cause of local recurrence today is a open biopsy done in the past. Needle biopsies are very easy to do. They are very low risk. Even if you place the needle biopsy tract wrongly, it can still be salvaged out. It should generally be image guided. That means it's either CT guided or USG guided or CARM or fluoroscopy guided. Very often the radiologists do it. So it's very important that you as a surgeon mark the incision that is going to be taken. Now why is this important? How would you biopsy the distal femur? Suppose you are suspecting an osteosarcoma or a GCP, where would you biopsy it from? What's your standard incision on the knee? Your standard incision is a midline incision, but that is not the incision for tumors. For tumors, it's either medial or lateral, because you want to save the patellar tendon, so you will not damage the extensor mechanism. So your biopsy has to be medial or lateral, completely against normal orthopedic incisions. And that's why you have to mark it. If you're sending it to radiologists, mark the incision line and then send it and tell them that you have to do the biopsy through this line, so that you don't place it wrong. Yes. So what is a J needle? What needle do you use for a biopsy? Sure. So if you have a bone biopsy, you must use a Jamshedi needle because it is very sharp and can penetrate the bone. That's what it looks like. Yes. There is a trocar, there is a cannula, and there is a pusher to push the material out. I'm going to show you exactly how a biopsy is done. What is this? Excision biopsy done for a popliteal tumor. They were not able to remove the tumor because the tumor was very close to the neurovascular bundle. They contaminated everything, and then the patient came to us. No option but to do an amputation. This is an amputation which is purely because a surgeon did not apply his mind and did an open biopsy without thinking. And this is something to be avoided. This is not something you want in your career. Today you can get sued for this and you have no defense.
What about bleeding during a biopsy and the risk of contaminating your compartments because of that bleeding?
So when you do a biopsy, you can do it under tourniquet also. If it is a very vascular tumor, like GCPs are very vascular. But with a needle biopsy, you can always put pressure. And you have to maintain that pressure for a long period of time to prevent a hematoma. For aneurysmal bone cyst, you can get the blood going up to the ceiling. It can bleed that much. The pressure is that high. So, but with needle, because your bleeding is controlled, you can control the bleeding. And there are times when very vascular tumors like alveolar soft part sarcomas, they are very, very vascular. Or thyroid mets, you can actually embolize the patient immediately after the biopsy. So our biopsies are usually done by the interventional radiologists, and if they find that the bleeding is excessive, the same time they will do an angio and embolization of that so that the bleeding stops at that time. So that's the reason why some of the tumors require tumor centers to be taken care of, and it is best not to put your hand into them even for a biopsy. But you must have the judgment what you can biopsy and what you cannot biopsy. What is wrong here? This is a big open biopsy. Can you see that scar and hatch marks? And can you see that drain site, which is far away from the open biopsy scar? This is something which means that entire area is contaminated and we have to do an amputation because you don't have any good tissue left. Open biopsy is a high-risk procedure and not to be done except by the institute which is going to do the final procedure. Okay, so even in the exam, if the examiner asks you, will you do an open biopsy, you say no. Okay? Even I don't do even once in a year. Less than one in a year. No, it's probably less than 0.1% chance of requiring an open biopsy. Very rare that you need an open biopsy. Now the question of where do you do the biopsy from, I think this is something which all of you should know. Different sites, where would you do the biopsy from? So the knee, which we were discussing. Now, this is an open biopsy, very well done open biopsy, but look at the amount of skin that you have to remove. If you remove this much skin, your closure is going to be an issue even after limb salvage surgery. Whereas if you did a needle biopsy, you remove much less tissue and you can always get a closure. So if you are going to think of doing a limb saving surgery, better to do a needle biopsy than an open biopsy in any case. These are the standard incisions, medial or lateral. What about the shoulder? You will not do it in the deltopectoral line because that is loose facial tissue. If you have bleeding, it will track all along that facial plane and contaminate. So you have to do it a little lateral to it from the anterior deltoid fibers because then the hematoma is limited by the muscle fibers on that. So just remember these things that when you draw that line, it has to be a little bit lateral to the deltopectoral incision because you can still take the deltopectoral incision for your approach to the shoulder on that. Similarly on the femur, it's going to be lateral. So even if you had a tumor in the head of the femur and you are suspecting it to be malignant, your biopsy is going to be from the lateral side, from the trochanter. Because if you if you go from the anterior side, you contaminate the joint. And once you contaminate the joint, then you have to do an extra-articular dissection, which means acetabulum also has to be removed. So think a lot before planning a biopsy. This is a true cut biopsy gun. True cut biopsy gun is used for biopsy of soft tissue. There is a trigger on the back, that's why it's called gun. You saw that noise which came. That's the actual noise. To mark the incision, you can do it under local anesthesia. Don't infiltrate into the tumor, it will contaminate. Just the skin. Bone tumors which have a soft tissue mass don't require bone to be biopsied. You can biopsy the soft tissue mass. Advantage of needle biopsies, you can go from the same point of entry into different sites, so you don't get a sampling error. And most good pathologists today can give you a diagnosis on this small amount of tissue. Can you see the course? How does this needle work? So this we filmed with high-speed camera and then played it slow to show you. So there is a trocar and there is a cannula of that. So first the trocar goes in. When you see, you fire that gun, then the cannula goes in and takes out that core, and that's how you get that core within that needle, and it happens so fast that you don't see it. with the eye. That is a bone biopsy. So again, small incision into that tumor, and that's a J needle, which you can see. So once you have reached the tumor, you will take out the trocar and then you will core into the bone so that the core of tissue gets trapped within the hollow needle. J needles which are going to go into the bone are painful. So please do it under general anesthesia. Don't try to do it under local anesthesia. With the patient jumping, screaming and howling, you will not get proper tissue. So you can get codes like that. These are very easy to do. Therefore, doing a needle biopsy should not be a problem for anybody. In fact, the soft tissue biopsies can be done in your OPD. They're so simple to do. Children get it done without any problem. You don't need them fasting, you don't need anesthesia, and they don't require any admission, so that reduces the cost significantly. Now this is what you do when you are going to scrape a cystic lesion with a needle. So under guidance you can see how the needle can go and scrape the wall of the lesion, and then you will get enough material to make a diagnosis. So we usually, in more than 90% of our cystic lesions, we get a diagnosis, either ABC, UBC, or chondromyxoid fibroma, or anything like that, telangiectatic osteosarcoma. You end up with a diagnosis. We showed you this case before. Now, that's the basics. Any questions on this before the last part of the talk is going to be how to answer questions that will come from these cases. Any questions that you have up to the point of workup, X-rays and examination? All clear? Okay, I'm going to ask you questions then, since you have understood so well. So the next question is, for a distal femur osteosarcoma, will you do an amputation or will you do a limb salvage procedure? So you say limb salvage. Don't you think you are increasing the patient's risk of dying of osteosarcoma? Is that correct? That's why this data, there is no difference in survival between limb salvage versus amputation when you do a limb salvage with proper margins. What are proper margins? Have you all heard of proper margins? Wide margin, radical margin, intralesional margin, marginal margin. How do you decide the patient is suitable for limb salvage? Only two conditions. It should be possible to get a wide margin. I'm going to talk about what is a wide margin to you now. And the second is what is left after removing the tumor should be adequate to give you function. If the limb is not going to be functional, there is no point in doing a limb salvage. Have you seen this picture from any King's book or article? This is tumor. So if you remove it from the reactive zone or from the capsule, it is called as a marginal excision. If you scrape it out like you do in a GCT, it's a intralesional excision. If you take it out with a cuff of normal tissue, it is wide excision. And if you take it out with the compartment, then it is a radical excision. Now, everybody knows that you don't require radical excisions anymore. A wide excision is good enough to get the same survival as what you would get with an amputation. Though your local recurrence rates may be a little higher than an amputation, your ultimate survival is the same. How wide should be, how much normal tissue should you take when you are doing a limb salvage? So common question asked, in the bone, suppose you are seeing the MRI extent of say 10 centimeters from the joint, how much should be a wide margin? 3 centimeters from the marrow extent. What about the soft tissue? So it is one layer of healthy tissue, whether it's going to be a good tissue like fascia or a healthy muscle. That should be a normal margin that you take when you excise the tumor. It could be the joint line, it could be the physis, which is a good margin. So a physis or a joint line is considered equivalent to 5 centimeter margin when you look at it. If the neurovascular bundle, you see this is a proximal tibia osteosarcoma. Now the neurovascular bundle is on the capsule. Is this acceptable? So over a period of time, as these cases have been studied, we know that this has not resulted in a higher rate of local recurrence. So if the neurovascular bundle is not infiltrated by the tumor and it falls off very comfortably, then that is an acceptable margin. So a focally marginal margin in the area of a neurovascular structure is an acceptable margin. Giant cell tumors are common cases you know in the exam. What are the principles of surgery? Anybody wants to say? Look at the pictures and say. Okay, the first thing is adequate exposure. Okay, so we say make a large window. Think of it not a window, make a door. You must see the tumor for 360 degrees before you curate it, because if you don't see the tumor, you leave tumor behind. So visualization is extremely important. After visualization, you curate the tumor. But remember, curettage is not enough. After curating, you have to use a high-speed burr, because there are a lot of bony ridges which have to be broken down. So if you don't use a high-speed burr, your local recurrence rates are much higher. So a burr today is a standard part. It is not an adjuvant. It's a necessary part of extended curettage. And what do you mean by an extended curettage? Extended means you have gone beyond what the obvious margin look like on imaging. So you have to go a few millimeters beyond, maybe 2 millimeters beyond or 5 millimeters beyond what is visible on the imaging. So that is an extended curettage. And then you use adjuvants. So the adjuvants that you use are different kinds. You've got thermal, chemical. So which are the chemical adjuvants? So phenol used to be used. We don't use it anymore because of the danger of toxicity. So we are now using a different thing which is safe, which is hydrogen peroxide. Now a lot of studies have shown that hydrogen peroxide is as good as phenol in terms of preventing local recurrence. So, and it is safe. You can even use 100% hydrogen peroxide and not end up with any trouble on the tissues. Whereas phenol is a very dangerous chemical to use. It has to be washed away completely, because if you leave behind phenol, you can get toxicity, neurotoxicity. Second thing is, if you use hydrogen peroxide after phenol and it bubbles, you can get burns. If it splashes on somebody's skin or face, it will cause deep burns. It's carbonic acid, remember that. So we don't use that. Now, thermal adjuvants, you can use heat or cold. Cold, you know, cryosurgery was used in the past. We don't use it because you can't control the amount of cold penetration into the bone. And they sometimes end up with fractures because of the necrosis of the bone caused by the cryo. So we use heat. There's an argon plasma cautery which gives you a flame. You see here. So on this handpiece, it's like a cautery. You get a flame. And with that flame, under vision, you burn the tissue. And this penetration is 0.8 millimeters only. So it is very well controlled. You can actually see the charring of the cavity so that you know that the complete cavity has been cauterized. So that is what we are using to. So these are the principles of giant cell tumor surgery. Unless you have all this available, you will not do giant cell tumor surgery. You must have a high-speed burn. The bare essential is you must have high-speed burn. You must use light, because otherwise the cavity will not be illuminated and you can miss a tumor. Magnification always helps you because it's all about visualization. So we use loop, we use light, we use that high-speed burn, You use C arm because you want to know that you have gone beyond the extent of the margin and done an extended curettage, and that's the argon plasma which you can see here. You can see that flame on that. A common question asked to you if you do a limb salvage surgery, aren't hinged prostheses bad for the patient? How long would they last? Any answer? So, if you use a good quality implant, then the survivals are good. These are constrained implants. We know these are hinged prostheses, but look at the data. There are multiple studies, and you can see that at 10 years, the average survival is 70% or more, which is not bad. And most of the time, what is revised are just the plastic bushings. So, which is a very simple revision, which means you should not be scared of using a mega prosthesis for these patients. And I can tell you now with 25 years of experience that these implants do last very well and give you a quality of life for these patients. So if your examiner challenges you on that, you have the data in front of you to show that these are not bad. Now if you use a bad quality implant, these are going to fail, and these are going to create problems for the patient. These are the bushings. I'm just showing you some pictures so that it remains in your mind. You can see the wear of the bushings, which happens, and that can be changed very comfortably. Sometimes you get an aseptic loosening, which is also very easy to change. You just re-cement the prosthesis back. What about arthrodesis? Is arthrodesis a good surgery for the knee? For a patient of giant cell tumor distal femur, if you're doing a resection, would you do an arthrodesis or will you do a joint replacement? A lot of your examiners are that old school and they tell you arthrodesis because they've done lots of arthrodesis. Arthrodesis creates more handicap than a rotation plasty. It's not a good operation. Patient practically has a lot of difficulty. So what is the difficulty that an arthrodesis patient faces, a knee arthrodesis? Traveling in public transport, in the bus, they have to sit with their legs straight out and people keep falling over it. Climbing railway bridges is a problem because they are slow. They have to do one step at a time. They are not fast, and that's why they are a nuisance for all the others who want to go very fast on that. Other than not being able to use Indian style toilets, public toilets, that becomes sometimes a problem. So arthrodesis is not a good option unless you have no other option. Patient can't afford a prosthesis or has no quadriceps. In today's world, even if you have no quadriceps, you can take a latissimus dorsi and do what is called as a functioning muscle transfer, and it works on that. So today, if I have to choose, I would probably never choose an arthrodesis unless the patient can't afford a good quality prosthesis. Remember, giant cell tumor patients are not going to die. So a good quality prosthesis is very important if you are choosing to use a prosthesis. What do you do for non-joint defects, that means intercalary defects? You don't use Elizarov bone transfer in tumor cases because they are undergoing chemotherapy. And chemotherapy interferes with bone regenerate forming. Plus the twin tract infections are a big risk when your white blood cell counts are low. So we generally prefer a one-step procedure. If the defect is less than 10 centimeters, we use a non-vascularized fibula. You can use allograft. And if the defect is more than 15 centimeters, then you combine whatever you're doing, allograft, ECRT with a vascularized fibula, and that always works for these patients. Okay, so this is what it is done, what we do today. Either an allograft or the patient's own bone is radiated outside the body and then put back. That is called as extracorporeal radiation and reimplantation. And that you combine with a vascularized fibula and you never have a problem of the junctions healing. or the patient having a problem in future. These biological reconstructions can last a lifetime without requiring any treatment. So in the exam, if you have to choose, that's going to be your method of choice. Okay. Intercalary allografts in India, because we are using radiated grafts, don't have a good success rate. Only 40% heal. So you have to combine them with a vascularized fibula and then 100% will. This is an example of a 26 centimeter defect treated with an allograft with vascularized fibula. You can see how well the whole bone has been healed.